Hello, I'm Rob Buckman, this is Peter Maguire, and this series of 5 programmes is designed for anybody in the medical profession to help them deal with a situation in which they're talking to patients about serious illness. In other words, what we're talking about is whether you're a medical student, a doctor, a nurse, a social worker, anybody talking to a patient who isn't getting better. Not the kind of situation where you can say you'll be all right by Friday or finish the course of tablets or something like that, but somebody who isn't getting better. And when you're in that situation, a lot of problems occur to you. What should we tell them? Should we tell them anything? If we want to tell them something, how should we break the news and how should we talk to them and how should we find out from them what is bothering them? Well, this series of programmes is designed to offer you a series of possible choices, of possible approaches to these kind of problems. And I thought what I'd do first is to give you a sort of bird's eye view or outline of the series of 5 programmes. What we've chosen to do is to follow the design or structure of one kind of interview. First of all, we set the context of the interview, just getting the physical surroundings right to allow easy conversation, and starting off with an introduction, finding out how the patient is feeling. Then going on to find out what the patient knows about the illness and how much the patient wants to know, how much information they would like to receive. And that will be dealt with in the first 2 programmes. And the next 2 programmes deal with the major difficulties that you may encounter. Anger, denial, series of reactions, series of ways of approaching the problems that the patients may bring to you. And then we show how you should end an interview with some form of a summary and a contract for future interviews or future follow-up or some arrangement for the future. And then finally, in programme 5, we show you the whole thing in action, a complete way of starting an interview, following through and concluding. So that's basically the outline of the 5 programmes, but there are perhaps just 2 general points that we'd like to make before we begin. And the first one is that what we're talking about is feasible in real life. We're not talking about some idealised academic doctor who's got hours and hours to spend with every patient. The kind of situations we're illustrating in these series of programmes can be dealt with in real life on busy medical wards, on busy surgical wards, or in general practice. We're talking about interviews that may last 10, perhaps 15 minutes, but not 2 hours. And the second point, which is a most important one, is that there are no correct answers. There is no single way of conducting a difficult interview that will always work out optimally for both doctor and patient. In other words, that what we're offering you are some of the alternatives and some of the options. So I don't want you to feel, as you see this programme, that we're showing you the only possible way, but I hope that it will stimulate you to think of other ways on your own. Why is it important that we do communicate effectively with our patients? Why does it matter?
Well, let's take what I think is one of the most important tasks. You have to try and establish what a patient is ready to know or wants to know. Now, if you get that wrong, quite serious problems can result. I mean, for example, if somebody wants to know and you withhold the information, he's going to become increasingly isolated.
Well, actually, we've done a role play, haven't we, based on your real-life experiences, the way real patients behave, in which a patient describes how he suspects that he has cancer, in this case, cancer of the lung, and his feelings on not being able to discuss it. Let's have a look at that illustration now.
Right. I think they feel you've been a bit under the weather, is that right?
Well, I've been feeling terrible.
Terrible?
Really,
in what way?
Terrible. The nurses, you know, when I was in hospital before, the nurses would cheerful, you know, they stop and talk to you on the way past and cheer you up. It's, now they don't, you know, they come and do what they have to do, tidy the bed up and that, and then they scuttle off as fast as they can. You know, doctors are the same, you know, they do what they have to do and then they're away, you know, give you the treatment and off. You know, so it's got to be a bit more than what they're saying.
No. So you've really got into quite a terrible state, haven't you, through worrying about this and not knowing what was going on and feeling there's a big difference in the way you're being treated and everybody ignoring you?
Yeah. I feel like I've got plague, you know.
Feel like you've got...
Like as if you're a leper, you know.
Sounds quite awful.
Yeah.
Yes, I mean, that feeling of I've got plague or I've got leprosy or everyone's avoiding me is very common, isn't it?
Oh, yes, and I think it really conveys the degree of isolation that patients like that actually feel.
Well, in the next bit of that role play, he goes on to reveal not only that he's isolated from the team in the hospital, the doctors and nurses, but also from his wife. And then he goes on to describe the feelings of depression. Now, you've done a lot of work in this. How common is severe depression that us ordinary doctors flipping past wouldn't detect in patients with cancer or serious illness?
Well, I think to put it in perspective, certainly at least 1 in 4 patients will get really quite seriously depressed. And in general, probably only a fifth of those will be recognised by the doctors or nurses. And that's entirely down to their communication or lack of it.
So any doctor who says none of my seriously ill patients ever have depressive illness isn't telling the truth, and even the best detectors are still missing a few percent.
No, and of course it's a self-fulfilling prophecy, because he won't be asking his patients how they're feeling, they won't be telling him, so it naturally then turns around and says there aren't any problems.
Well, let's have a look at the bit in which he describes the isolation from his wife and the depth of his depression.
Right. Is there any other reason why you feel you've got a growth?
Well, there's the way the wife's been acting, for one thing. She's come in, and I've had bronchitis before, you know, and bad chest, and that. She's been all right and cheerful, trying to buck me up.
Yeah.
And now she's quiet, you know, and hardly talk. When she does talk, she's rattling on about something and nothing, you know, and looking anywhere and everywhere but at me.
Why do you think she's doing that?
Because she don't want me to know.
So you think everybody's holding back on you, do you?
Yeah.
Particularly your wife?
Yeah. I think she might have told him that.
Mm-hmm. And how does that leave you feeling in yourself?
Well, it makes me feel bad, you know. It's I'm not getting me sleep or anything, you know, with worrying about it at night.
Sorry, you're not getting your sleep because of worrying about it?
Yeah, well, I'm thinking about this thing growing, you know, gnawing away.
And how's that interfering with your sleep?
Well, I'm lying awake late at night, you know, everything's quiet and you've got nothing else to think about but this thing growing and growing all the time.
And how strong are those worries at night?
They're very strong.
Very strong. Do you get any relief from them at the moment?
No.
What time do you wake up?
About 3 or 4 in the morning, that's another thing, you know.
Mm-hmm. And what time do you get back off after that or not?
No. You know, I'm tired and all that, but
yeah.
I can't get back to sleep.
Yeah. And how do you feel when you wake in the early hours?
I feel rough. I feel, you know, it all comes back again. As, you know, oh, God, no, you know.
Oh, God, no.
The things going round and round in your mind, your imagination, that picturing this thing living inside you. And
that sounds quite terrifying.
Well, it is.
Yes.
I mean, it's bound to be, isn't it?
Yeah. Does it affect the way you feel in any other way, apart from feeling rough and worrying about things?
Tired and washed out, you know.
Yeah. How have you been in your spirits during this time?
Very low.
Very low?
Yeah.
Can you tell me?
It was diabolical, actually, you know.
Diabolical?
Yeah.
Just how low have you got?
Well, it's about as low as you can get. I mean, that's not me normally. Normally, I'm quite lively, you know.
So there's been a very big change in you from being very lively to now being as low as you can get?
Yeah.
Do you ever get so low you don't see a future for yourself?
Well, you get thinking so that, you know, what's the use of carrying on, you know?
What's the use of carrying on? You get that low?
Yeah.
Have you ever got to the point of contemplating taking your life?
Well, I thought about it, you know.
You thought about it?
So let's think for a moment about precisely why it is so difficult to tell Mr. Fletcher there what he's got wrong with him. Why is it so awkward, and why don't they tell him? Well, in the booklet accompanying this series of programmes, we've detailed at great length the major difficulties that doctors and nurses and everybody else have in breaking bad news to patients and discussing serious illness. But I thought, just for the moment, it might be a good idea to give a very brief resume of that material in the booklet, so that at least we have it in our minds as we proceed. And I've divided the major difficulties and obstacles to good communication and breaking bad news into two categories. Firstly, the kind of things that we all feel as human beings when confronted with a situation of breaking bad news. And secondly, those groups of fears and difficulties that are particularly brought out or induced in us by our training, whether it's medical school training or nursing school or any other form of professional training. Let's look at the personal fears and obstacles first of all. First one is that breaking bad news causes pain. And none of us, particularly doctors and nurses, like causing pain. In fact, doctors and nurses are trained to alleviate it rather than cause it. And so when we have to cause pain, we tend to shy away from it. Secondly, a very important thing, that we don't want to get blamed. And I think that all human beings like to blame the bearer of bad news for the bad news itself. It's easier to cope with bad news, not in the abstract, but by personifying it and blaming the bearer. Like, for instance, a traffic warden. Your real anger and rage when you get a parking ticket is against the ticket. But it's so much easier to actually blame this particular traffic warden who you think is enjoying it, or she could have gone round the block again, or she can see I'm a doctor, or something like that. So blaming the bearer for the bad news is a very common trait of human behaviour, and I think that we, as doctors and nurses, fear it when it's our turn to hand out the bad news. Thirdly, our own fear of illness and death. Now, this is a difficult area, but some people believe that all doctors and nurses, to some extent, become doctors and nurses out of a way of denying the possibility of them becoming ill and dying. In other words, to some extent, I am a doctor because it comforts me to work with people who are seriously ill, and yet I am not seriously ill myself. Now, if I am afraid of my own illness and my own death, then I will shy away from a patient who is ill and may be dying, because if I find out that we've got a lot in common, it might occur to me that maybe this could happen to me. So another fear, in other words, is my own fear of illness and death. Now onto the group of fears that we, as it were, learn during medical school. Well, the first one is that by and large, talking to dying patients or breaking bad news is something that isn't taught. Now, doctors and nurses alike enjoy, usually, doing the things they've been taught to do. If you're coping with diabetic coma, coping with a cardiac arrest, laying up a lumbar puncture trolley, it doesn't matter what it is. If you've been taught how to do it, there is a certain reward in doing what you've been trained to do. And if it goes wrong, and let's say, unfortunately, the cardiac arrest is unsuccessful, you say, well, at least I did my best, fine, perhaps nobody else could have done much better. Now, that is, as I say, a rewarding thing to do. It is very unrewarding and very unpleasant to blunder into an area in which you haven't been taught. And certainly, most medical students now qualifying won't have been taught, and so they will avoid a situation in which they haven't got some form of guidelines laid down. Secondly, in this group of causes, there is the fear of precipitating a reaction. What happens if this patient bursts into tears, if she gets angry, if she becomes upset? You know, all the other doctors and nurses looking at you, the kind of doctor who makes people cry. It's very difficult for any of us to believe really in our hearts that it's all right that a patient cries, that it is actually a good thing that the patient flatters us, trusts us sufficiently to break down and cry while we are there to help them. The fear of precipitating a reaction or upsetting, in its wider sense, the patient is a very important one. Thirdly, the fear of expressing our own emotion. Of course, all of us who look after patients are not supposed to express panic, even if we feel it, and we're not supposed to express anger. We're not allowed to get irritated with our patients. And that extends in a funny sort of a way to the idea that really a good doctor and a good nurse, they don't express any emotion. They're cool and calm and absolutely stable. And of course, very often, patients would like us to express some helpful emotions, sympathy and empathy, but because gradually in our training the idea builds up that it's a good idea not to express emotions, when it comes to expressing sympathy or empathy, we don't know how to do it, and we have to sort of relearn. The fourth cause is the one of not knowing all the answers. Now, in all trainings, in examinations, nobody ever rewards you for saying, I don't know. They say, come and take the exam again then. They don't actually congratulate you for being honest. But very often, patients would like us to be honest, even if the honest answer is, I don't know. I believe that the general public no longer expect omnipotence and omniscience from the medical team. They don't expect them to be able to do everything and know everything. And I think that if we can persuade ourselves that it's all right, it's permissible to say, I don't know, we'll be a lot better off in the way of helping our patients. And finally, a very difficult one, the fear of upsetting the medical hierarchy, the fear of saying something to the patient in the bed that you've been told from above, whether it's a senior sister or a consultant, you are not to tell them. A patient can be riddled with pain and visibly dying day by day. The patient knows that, everybody else knows that. And yet, when the patient asks you, you have this terrible feeling that you ought not to say something if you've been told by the forces above you that you ought not to be saying it. Now, for all those reasons, for all those obstacles and difficulties that get in the way and make this situation of breaking bad news so awkward and difficult for us, for all those reasons, unfortunately, the moment of breaking bad news quite often looks a bit like this.
Well, there you are, then. You've got a little ulcer in the bowel, and we're going to take away all of the ulcer on Friday. Nothing much to worry about.
I just wondered whether it was anything serious.
Oh, I don't think it will help you to worry about things like that. There weren't any more questions, were there?
Is it just an ulcer, Doctor?
Sister, if you could have a quiet turn to sort it out, not...
I just wanted to know whether it's...
We'll
something
cure you on
serious
Friday,
than
then.
that. Could you
Right,
just
let's
tell
have
me...
a look at the hemorrhoids in bed number 11.
And he sweeps onwards to talk to the hemorrhoids in bed 11. We're left wishing that that never actually occurred in real life.
That's right.
But, Peter, before we actually come to the stage of actually setting up the interview, we have to have the objective or the purpose of the interview in mind. And the objective or the purpose depends to a large extent on what we have to do. And you've drawn a distinction between front line and second line. Can you explain that?
Well, talking about frontline personnel, I really mean the doctor who has made the diagnosis and, as it were, has the ultimate responsibility for the patient, because he really is the first one to have to decide whether the patient should know or not. So that's what I really mean by front line. In other words, it's very difficult for him to avoid making some kind of decision about that. When I use the phrase second line, I don't mean to diminish the role of other doctors and nurses, but they're in the position of, as it were, trying to pick up what's already happened and to try and relate to the patient when somebody else may already have made a decision about telling or not telling. So that's the sense in which I think second line is an appropriate phrase, because the problems faced by them are rather different than the initial doctor.
Yeah, and of course, a second liner can also be the bloke who was in the front line later on after the news is broken.
Right.
So if I've already told you something serious, I might come back later on as a sort of second line in order to follow through. Well, in order to set up the interview, before we come on to the introduction to the interview, then the main bit and the conclusion, let's first of all look at the setting, because the actual physical setting, the actual way in which you physically relate in space to the person you're wanting to talk to can make a great deal of difference. And earlier on, we did a little bit of a demonstration in the ward area. Let's just have a look at that demonstration right now. Now then, what we have here is a classical how not to have an interview situation. The patient is naked and exposed. The rest of the ward can see everything and can hear everything. He's lying down flat, staring up at the ceiling. And if I adopt the bad doctor position for talking, I'm 6 feet away. I'm 3 feet above you, aren't I, Michael? I can see right up your nose. You can hardly see me at all. How do you feel at the moment?
Embarrassed.
Embarrassed and uncomfortable, I bet. But you can remedy this very, very easily. If you sit yourself up, I put your pyjama jacket on, important for men and women not to feel embarrassed and naked. If I pop a pillow behind you, you can sit up comfortably. And if I'm not using an interview room, I just draw the screens so at least I can create an illusion of privacy so that the rest of the ward don't feel they ought to be listening, even if they are. And if I sit down opposite you, then my eyes are on the same level as you. You're comfortable, we can see each other. I'm at a distance that's neither too distant nor actually threatening you. And do you feel now that you might be able to tell me, say, details about your bowel habit or sex life or anything?
Yes, it's much better.
Yeah, sure. Well, perhaps it seems obvious and perhaps it seems even a little bit silly and fussy, but it isn't. It's these kind of details that make the difference between success and failure. The difference between a patient lying naked, frozen with fear and embarrassment, hardly able to say anything at all, and a situation in which at least we maximize the chance of the patient saying what is really on their mind. Thanks. OK, well, let's assume that we've got that bit right and that we are literally sitting comfortably. Right. Peter, what's a good way to actually begin the conversation?
Well, I think the key thing is to use an open question.
What's an open question?
Well, I might say to the patient, for example, how have you been feeling since your operation? Now, the advantage of a question like that is it doesn't force the patient to pick on any particular area. It allows the patient to really say whatever's in their mind. It could be physical, psychological, or something else. Whereas if I say, is your pain better, I'm forcing him to talk about his pain, and I'm also, in a sense, biasing the answer to a favourable one.
Well, now, we've got a demonstration of what happens if you don't use an open question straight away, in which you have enacted, pretended that you're not good at open questions, and made an assumption and gone straight in. Let's look at what happens if you don't use an open question, first of all.
Right. I gather from our nurse who visited you that your op's gone very well.
Well, I don't really know how she knows. All she was worried about was the stitches.
OK, so if you don't start with an open question like, how are you feeling, and you've guessed wrong, you may have to sort of dig your way out of it a little bit. But assuming that you do start with a how are you feeling, or how are you, or how are things going, as a good open question, how do you get the patient to actually start talking, to sort of roll the show along, to actually get to what's bothering them?
Well, I think the first thing is to give them space, to let them talk, to know that it's legitimate for them to talk rather than you bombard them with questions. And as they talk, I think it's important to signal that you're listening by looking at them, showing interest, perhaps by nodding from time to time to keep them talking. And a useful trick is to pick up the words they've just used. For example, you know, you were telling me you had a pain, OK? And you can also pick up cues. For example, if somebody says, I've been very worried, then it helps if you say, would you like to tell me what you've been worried about? OK? Now, that not only prompts them to continue talking, but it helps you get into what's been worrying them. So, as it were, the dialogue gets into deeper matters, and most importantly, into what's really bothering the patient.
Well, now, let's have a look at another role play, again, as we must stress, based on real-life interviews, in which you very well use a variety of these techniques to draw out your patient about her various worries. Let's have a look at that.
Right. You sound a bit upset.
Well, I am. It's awful.
What's awful?
What I'm left with, the hole.
What you're left with, the hole. Can you tell me about it?
It's much bigger than I thought. She just kept saying how lucky I was that I hadn't had a mastectomy, but it looks really terrible.
In what way does it look terrible to you?
Well, it's ugly. I'll be no use to anyone with this. It's awful.
It feels ugly, and you feel you'll be no use to anyone?
Yeah, it's just awful. I mean, well, it just looks terrible. I feel...
You feel?
Well, not complete somehow.
Not complete?
And I didn't think I'd feel like that with just a part of it gone, but it really is terrible.
Have you been able to look at it properly?
Well, I have.
What about your husband?
Oh, no, I couldn't let him see it.
What's stopping you?
Well, I just wouldn't like him to see it. It really is terrible.
But what do you think would happen if he looked?
Well, I don't think he'd like it at all. I mean, he's been very good. I mean, he really has been kind.
Yeah.
But I don't think he could fancy me with it like that.
You think it'd put him off you, do you?
Yeah, it's put me off me, hasn't it?
Yes, it sounds like it. Has this affected you in any other way other than feeling so terrible about the way you look?
Well, I'm worried as... Well, I'm worried.
Mm-hmm. Worried?
I'm worried that they didn't take all the cancer away. Really.
Is there any reason why you should think that?
Just the way it is.
You mean the size of the hole has really shaken you?
Yeah.
Well, that demonstration shows how simply, just by nodding and pausing and repeating the last words, you quickly draw the patient out, and how well she described the situation as she saw it, and how quickly that description came out. This is a technique you can try yourselves. When you're talking to anyone, boyfriend, girlfriend, mother, anybody, just try repeating the last 3 words of each of their sentences when they finish, and notice how the conversation progresses. I promise you, they won't notice. It's well worth a try. Let's summarise what we've learnt so far. Now, you may think that what we've actually learnt so far is very unimportant, because all we've really looked at is how to sit down comfortably on a level with our patient and ask a few simple questions like, how are you? And then to nod and pause and repeat their last words. But let me stress quite genuinely that these are very, very important things, and that if you start off a discussion badly, it's almost impossible to recover it. And ignoring these kind of apparently very simple and obvious details are precisely what gets interviews off to a bad start from the beginning. So that really concludes what we've learned at the end of Programme 1. In Programme 2, we'll be looking at how you establish what the patient already knows about their illness and what they would like to know. So I hope that at a suitable point or after suitable refreshment, you'll join us for Programme 2.